now you're dealing with maybe somebody that's even combative with you because they're just so scared and confused.
So I think it's really important, keep your hands up, speak in a tone to the care provider and to the patient.
Yep.
That's calm.
Calm, slow.
Yeah, nice and
knowledgeable, sound like you're confident in what you're doing.
You are listening to EMS with your hosts, Erik and Matt Ball.
So we're talking about a unique topic today. Patient
Special.
Population.
Yes. I think I have some friends with children with special needs. I don't think any of us could begin to understand the difficulties, not only that the parents might experience in taking care of a special needs patient, because oftentimes, unfortunately, they don't live long enough to become an adult, but and then we also have the special needs patient population of adults that we can never begin to understand how difficult it would be to live in this world with a special need.
Yeah. Well, I think it's important to define what exactly is a special needs. Like what category do people fall under that would be considered a special needs patient? Yeah,
I think if I were to define special needs, it's in the EMS context anyway, it's a patient with intellectual challenges, behavioral challenges, developmental challenges, that I think, and physical challenges. Those would be, I think, the quick and dirty definition of a special needs patient in the EMS context.
Right. And it's important for us as in-hospital and out-of-hospital providers to understand, their world a little bit and how they respond to things, how they communicate, like autistic kids, some of them are nonverbal. So how do we communicate as first responders with these patients, That's super important for us to know how, because we can't do a proper assessment if we can't properly communicate with our patients.
Right. And some of these patients, as we get to that, we'll talk about how we really communicate. Sometimes you can't communicate with the patient. You're going to be talking to their caregivers.
That's right. Which is huge thing.
If you don't access that, you're really missing the boat.
Yes. This is one patient population, just like any kids. Like, I think most pre-hospital providers are pretty good about incorporating the parents. Typically, the parent is on scene when you have a pediatric patient, or else that kid's going to be freaking out. And I think that's similar to a patient with special needs, is that caregiver is their safe space. And we want to utilize them. This is the time that, that caregiver is riding in the back of the ambulance with me, because that is my patient's safe space. That's going to keep them calm and allow me to do what I need to do as a paramedic in the back of the box, and help with assessment and communication and all those different things, and understanding what's their baseline. What are they always nonverbal, or can they talk? Are they able to answer these questions?
I think you brought up a really good point. Is that there's a spectrum of disease within each of these categories of special needs. So, like we said, within that EMS context, the physical challenges, those physical barriers. It could be an adult without legs, or it could be a child
vision
with
impaired.
like I think it's called amniotic band syndrome. I know there's a couple NFL athletes that had poor limb development because of some amniotic or gestational sort of complications. So those physical, mentally, the brains wasn't affected. It's just they don't have a fully functional arm or whatever. So. The intellectual stuff, the intellectual disabilities, the intellectual barriers, where maybe it's because of cerebral palsy or some traumatic brain injury,
autism, developmental delays,
developmental delays. Those intellectual and developmental delays create some barriers in communication, some barriers in treatment. Where this adult, I'll never forget. Great story.
Okay.
I went to a special friend's prom.
Oh, yeah.
I was in
the Tim Tebow thing?
Yeah, it was like that, but it wasn't with
Tim
Tim
it wasn't
Tebow
the actual.
But Tim does a great job.
Oh, he does. He's a phenomenal human, yeah.
It really is. I got to see, we did a fundraiser with him. We got to meet him, and we got to see some video footage of his special friend's prom that he's a part of, but we did one at our church.
Oh, okay.
And I'll never forget, it was so special. In fact, this my special friend that I took to the prom,
Oh, you actually took somebody to
Yeah,
the,
yeah.
oh.
Well, they kind of match us up with a special friend.
Okay.
And I went to the prom, and it's like a fair kind of a thing where we would take them to different booths and play games, and it was just a fun party atmosphere. We took lots of pictures. It's really celebrating them and having a good time.
Yeah.
They don't get to do a lot of these things living in their group homes
Right.
and whatever. So my special friend has some developmental and intellectual barriers that make it difficult. But I remember when I met him, tons of joy. I mean, loved playing games. We had a really good time together. And it was interesting. He's 47 years old.
Oh, okay.
I had no idea. I mean, he looked younger than that.
Yeah.
But functionally, though, and trying to treat him if there was a medical emergency with him as a 47-year-old male, it'd be difficult for me to communicate with him like I could maybe not normal, but a typical 47-year-old who I could articulate, hey, you're having a heart attack.
Right.
With speaking to my friend who's 47 with some intellectual barriers, it would be very, very difficult for him to understand what's going on.
Right. Comprehend what's happening.
And you'd be communicating to this individual much different than you would someone like you about the same age.
Yeah.
Right?
I'd like to go back a few years.
Yeah, right, I know. But I think that's true. So whether it's a physical barrier or an intellectual, developmental, and I can't remember the fourth one we talked about. Oh, sorry, yeah.
Yeah, physical.
These delays or barriers, I like the word barrier, really create some challenges for us in the EMS community in treating this very real patient population that oftentimes actually has more medical needs because of some of their comorbidities.
Right.
Some of these patients are trach dependent because of some physical and developmental and cognitive, whatever the barrier might be. A G-tube dependent, feeding. They can't eat like us, but they eat with get their nutrition through a G-tube.
Yep.
Like with some trach or a ventilator. There's a lot of challenges for us in the pre-hospital environment to treat these patients with very real medical conditions.
Yeah. Yeah, I think the biggest thing is back to communication. With all of these, whatever their barrier is, whether it's vision impaired or hearing impaired or developmentally impaired, whatever it is, communication is going to be the number one thing that is going to be difficult for us as first responders in dealing with these patients. And that's where their caregiver, whether it's a caregiver from a group home or the parent, is going to be crucial in bringing them in, because if they are hearing impaired, that person probably knows sign language.
That's right.
And can communicate, right? If they're vision impaired, then obviously they can hear.
What did you do in the back of an ambulance if you had a patient that was hearing impaired? What would you do to communicate with them? Is there anything you can do?
Oh, always. Well, we don't have any resources for hearing impaired. We don't have any resources that I know of. Like we have language line if somebody speaks a different language. But obviously, we do have some people in my department that actually spoke sign language a little bit, enough to get by. Or you could write stuff down. Obviously, with somebody that's hearing impaired, you could, which I've only had a very small 1 or 2 patients in my career. And so we would write stuff down a lot. But again, too, that's been an issue, too. You might think there's something medically going on with the patient, and because they're not answering you. And you might think they're altered or they're overdosed on something. And it's like, no, they just can't hear you, And then the typical fire response is, well, just talk louder. No, man. So writing things down for hearing impaired, vision impaired, obviously they can hear you, and normally they don't have any.
You're going to have to do more talking.
Yes.
To help them to understand what's
physical
happening.
touch. Like, hey, you're going to surprise them if you reach over and you go to start an IV on them, or I'm coming to grab your hand. Like, you're going to have to explain, use a lot more verbal, because they don't have that sense of sight to see what you're doing.
I think we sometimes forget that a person without a visual impairment, there's a lot of communication just by what we see and do.
Yes.
That's another point. We've actually talked about this in previous episodes, where most of the communication that we have is in tone and body language, right? So when you're visually impaired, You don't get a lot of that. You're going to have to over-communicate what you're doing, what you're planning to do, where they can see reaching for an IV. They know what's going to happen. Yeah. Where when you can't, you've got to talk about it. That's right. Interesting. My daughter's taking sign language.
Oh, cool.
Instead of Spanish, she's decided to get American Sign Language. And I'm excited for her to have that, the capability to be able to communicate with hearing impaired folks. I think that's a neat skill.
Super cool.
I've noticed, though, too, in the ER, I've had patients. Now, in the ER, we have like iPads where we can have a virtual experience where there's a sign language person. And that helps to, I think, make the or the communication more efficient.
Sure.
Right? This is better than writing it down.
Yes. Oh, for sure.
But at least it's something, right?
Yeah.
But they're also oftentimes, I've found, just expert at reading lips.
Oh, you are or they are? Oh,
Not me.
Yeah. Yes. Yeah, they are very good at that.
Yeah, I was spying on my neighbors the other day through the window, and I could read their lips, and they were talking about some weird neighbor they had.
It's like, that guy's an idiot.
Joke. Okay, it's just a joke.
And they're pointing in your
direction. It's a bad joke. Sorry.
No, but I think the other thing is, when you have like that autistic patient that is nonverbal,
right?
And not only are they nonverbal, they're processing information coming in differently than you and I process information. And so being very cautious in how we're communicating.
Yes.
But that's where, again, that caregiver is hugely important in getting them on board and helping you communicate with them to communicate with your patient.
Yep.
Finding out what's going on with them, if there's anything you need to do. That's hugely important. Some of them do not like to be touched.
Right.
Some patients with autism, they do not like to be touched.
Yep.
And so if you're in a situation where you have to put your hands on them for a treatment purpose, crucial how you communicate that with them.
If I could give you advice, only because as a teacher I had to teach a lot of kids with autism, and it was a challenge oftentimes where, and I told you before we filmed, I couldn't redecorate my room without be very careful even to change the environment because that could trigger some things. But you have to think about if there is a 911 call for a patient that happens to be autistic, can you imagine how much of a break from their normal pattern just that is alone?
Yeah.
I mean, if you can see somebody struggling or maybe even physically, having to be restrained by their caregiver just to get them to the ambulance, do we really need a blood pressure and a heart rate?
Yeah.
We know their heart's beating.
I think they're okay. Yeah.
Putting on the blood pressure cuff could really throw them over the edge, or the pulse ox on the finger even, You know what? Let's not worry about the vital signs right now. I think that's just for me. I know in the ER, oftentimes that's just not a battle. A hill I'm gonna die on.
Yeah.
I just, eventually when you're gonna need some vitals, but maybe let's build some rapport and some trust first.
Exactly.
I think you got to be very careful on how you spend your equity on patient contact with them. Too much contact, too many changes and crazy things could push them over the edge.
Light sirens on your apparatus, turn those off if needed. Turn those off. Don't overstimulate.
Yeah, that's
Again,
it.
Have the caretaker with you to keep them calm. You separate them from their caregiver. That could be another huge thing that could, set them off. And now you're not getting anything done. Now you're dealing with maybe somebody that's even combative with you because they're just so scared and confused.
Right. Regardless of the physical or emotional, or not emotional necessarily, or behavioral, I guess, intellectual, developmental, whatever it is that's creating a barrier for care, I think that being patient and this isn't going to happen the way a normal patient is treated. It's going to be a different process now.
Yes.
So forget about expectations on what you would have in a typical patient interaction.
Forget about your sample history. Forget about OPQ.
Right.
Yeah.
We'll get to communication later, but just don't expect those steps that you take for granted that are easy in a typical patient interaction are not going to be the same. Probably not going to be the same. And I think being patient and willing to take your time. Now, listen, if there's an emergent thing, I've had special needs that need to be intubated emergently.
Yeah.
That is what it is. So I'm sorry, but there's no time for being nice and talkative and and building rapport with verbal whatever. You got to save lives, right?
Yeah.
That's a choice that you're going to have to make, a decision you're going to have to make early on. But then we're not talking about those.
No, we're just talking about the standard patient and just dealing with them, from their standpoint. Keeping them comfortable and communicating with them, that's a huge part of it.
The other thing that I think is maybe the most important thing that we could talk about with taking care of a patient with special needs is to recognize how absolutely important it is, more than most patients, to involve caretakers and to respect caretakers, parents, whoever it is, facility, assistants and whatever that are there.
Maybe they have a nurse that's with them or whatever.
Right.
Yep.
This becomes paramount. This is not a load and go thing where you didn't get all the information you need. Absolutely crucial to understand the baseline of the patient, to understand all of the concerns that the staff had in calling 911.
Yep. If they are on a vent, if they have that G-tube or something like that, typically I've had numerous patients, little kids, that had trachs and they're on a vent, right? Yeah. Well, even as a nurse, I don't deal with vents much. I don't deal in a critical care environment. So that mom typically is an expert on how to run that vent.
Yeah.
They know exactly what they need to do. They know exactly what their O2 sats normally are. Because you might be seeing 90% thinking, oh my gosh, we got to get, nope, that's normal. Yep. That's his normal, right? But they know how to run that equipment. If I've had numerous ones, we get called a lot, a mucus plug. Yeah. They know how to swap those things out, right? Oh, yeah. But, I think that's under-trained on, how to deal with those patients. You can put a BVM right on that thing. It's called, and you can just bag your patient that's on there. Suction is your best friend. Yep. But again, like you said, the caretaker, the parents, a lot of times with the pediatric population, the parents are experts. They are absolute experts because not only, obviously they love and care for their children, right? So they want to know everything that they need to know about, caring for their child. So definitely utilize them, take them in the back with you on the way to the hospital.
One short story I'll say before we end this first part of our podcast.
I keep yawning, sir.
I'm boring.
You're boring me. Oh my gosh, doctor. No, I don't know what it is. I'm yawning today. Go ahead. Your story.
No. It's a pretty common experience that I've had in the ER anyway, is when we get a patient with a very complex medical history, a G-tube dependent, trach dependent. All of the vents and everything. Yep. It makes this patient with all of these medical barriers look very sick.
Yeah.
And a lot of my doctor colleagues will immediately start pressing the transfer button to a pediatric facility that can handle these things, right? But one thing I would do is I would hesitate to because you may not be pushing the transfer button,
right,
but you're pushing the button to go, okay, let's get this patient to the ER right now.
Yeah.
Diesel, right? Yeah. That's basically what a doctor is tempted to do in transferring somebody out. But one thing I would say is, and tied to what we just said, is respecting the caregivers. It's been so often that I've had a patient that would come in and they've got the chair, the mechanical kind of wheelchair, out there, and the ventilator, and the feed bags are hanging, and they got all the bags of stuff that
wires
they need to carry with them. Right. It's actually not tempting, but it's easy to just think to yourself, wow, this patient's sick. I'm gonna get them admitted, and I need to transfer them.
Yeah.
But if I talk to the caregiver and say, no, actually, what you're seeing right now is the baseline. My kiddos, actually, I think they're okay.
Yeah.
Here's my concern.
Yeah.
They yanked on their G-tube. I'm concerned that maybe the G-tube's not hooked up, right?
Right.
There may actually be a pretty benign issue, even though the patient looks medically fragile and scary, is to really put a lot of weight on that caregiver's story and get that context. There's no more important thing that you can do than to communicate with the caregiver with some of these patients that can't communicate for themselves.
Yeah, for sure. No, that's good.
There's a lot of really interesting things we're going to talk about today. There's some legal implications here that you want to really be careful of, that will tell some stories. There's also a lot with caring for, managing, if it just physically moving.
Yes.
There's a lot to talk about. We'll hit those up, I think, here next.
All right. So part one, we kind of defined what special needs patients are, the different types of a special needs patient: physically, developmentally delayed, emotional, mental.
And those needs, I like it. We kept using the word barrier. These are special barriers. Barriers you don't normally have to overcome to treat patients.
Right. And in this part, we're going to talk about, and we talked about it a little bit there, but the biggest one is communication.
Yeah.
Right? And a lot of that is not just the words that come out of your mouth. There's a lot of things, and you mentioned it in the first part, about how we communicate,
This
right?
reminded me of Chris Tucker.
Chris Tucker?
You understand the words?
Do you understand the words that are coming out of my mouth? Chris Tucker, he's funny.
Anyway, sorry.
But yeah, so how we approach the scene, right? Like coming up to that scene, like a huge thing, and really this goes to any call, is as first responders, we got to remain calm. Like if we start freaking out, I've been on these calls, or we've all, been on those fires where, command gets on scene and they're yelling and screaming and everything just gets amped up. Everybody's like, holy cow, what's going on, right?
Being calm.
Yes, and just the opposite. You have that incident command that's super calm, and you can watch these videos, and it's always impressive. One of the most impressive videos I've ever seen was the Beacon Hill fire, famous fatality fire, super unfortunate event, happened in Boston. And you can hear the radio transmissions between the firefighters that are trapped. And that guy is so calm. I mean, I've heard a lot of transmissions in my years of these, maydays and stuff. And even like guys that are, heavy duty firefighters, FDNY, Dallas, Boston, Houston, when you get put in that scary of a situation, that's terrifying, right? But this guy was so calm. So calm the whole time, like never freaked out. But again, that's how we have to approach these patients, right? Yeah. If we come in there and we see a kid laying in a bed with a G-tube and he's got a trach and he's got all these, like you said earlier, wires and buttons, we have a tendency to go, holy cow, I'm out of my league here. I don't know what I'm supposed to do, and we start freaking out. Even if it's like I always think of the duck on the water. Everybody's heard that analogy. On top, he's nice and smooth, and underneath those feet are just like inside, your brain's going a million miles a minute.
Yeah.
But outside,
calm down.
Stay calm. Stay calm. Don't freak out.
Yep.
And then the other thing we talked about extensively was utilizing the parent or the caregiver.
Yeah, and that's really part of the challenge here as we talk more about communication, is that you're not just dealing with one patient.
Yeah.
And it's even true for pediatrics from time to time. There are some barriers there with age and cognitive ability, but that's normal and expected. But with this patient population, the challenges and barriers are pretty diverse.
Yeah.
And it's so important that when you're communicating, and a lot of the communication and all of it sometimes might be with the caregiver.
Yep.
And having a respect for the caregiver and building that trust with the caregiver and the rapport with the caregiver, where the patient will feel comfortable seeing you getting along with the person that they know and trust.
Yep, 100%. Or the caregiver. A lot of times that could be an LVN if you're dealing with a pediatric patient with a lot of comorbidities. They're going to have probably an LVN. Normally that's not an RN. Could be an in-home RN, but a lot of times it's an LVN. But they're still extremely knowledgeable on that patient. They have probably dealt with that patient for months, if not years. Yep. They know everything about that patient, right? And they can tell you that.
I have a story. I was treating a patient once, and I could see they didn't speak English after I came in speaking English. And so I immediately assumed they were Spanish speaking, and I started speaking in Spanish, and they were Persian.
Oh, okay.
And I'm like, oh gosh, I feel like such an idiot, just stereotyping them, and like most of the time it's Spanish, and they were Persian, and one thing I have done, I was attending up at a medical school just north of us, and a huge medical school, and teaching my baby doctors. I remember one of the things that I would see in patients and sometimes it was from a language barrier, but I'm thinking of a specific story right now with a patient that had special needs.
Okay.
Who was fully cognitive, everything was fine. It was a traumatic brain injury in the past. It just affected their speech. Okay. But they would talk to them really loud, and it's like, wait a minute, this person, this adult, totally understands.
He's not hearing impaired. Why are you
talking to him this way?
Every single time you get a patient, almost without fail, in the fire service, I bet everybody that's in the fire service listening to this podcast has been on a call where somebody speaks Spanish or another language, and instantly somebody on the call just starts talking louder. And I've literally looked at a dude one time, and I'm like, bro, they're not deaf. They just don't speak English, but it's just our natural. Well, even if I talk louder, it'll get through to them.
Even if they're hearing impaired,
talking louder isn't going to help.
Right. Or if they're visually impaired, you don't have to talk. In fact, when somebody's blind, their sense of hearing is even more acute.
You're blowing out their eardrums, bro.
So
calm down.
It's funny how we tend to do that. Be aware of that, is that we have that tendency sometimes to not fully understand the situation of the patient. So be slow to really take your time to understand the context of things.
Right.
And, as you start to get to know the patient a little bit, you get to know the caregiver, you start to get the context.
Yeah.
Don't just jump in like a bull in a china store and, talk in Spanish to that Persian-speaking,
Right.
that kind of thing, right?
Right.
It's important to get the context because your communication is key in these things. You need the information to properly care for them. That 7 minutes of time, or if you have longer transports in a rural area, can really make the difference.
Huge difference. Huge difference in your overall care and the patient's experience as a whole.
Yeah.
So walking into these situations calmly, once you you see like, oh, this is somebody with special needs. Maybe they're in a wheelchair or whatever the case may be. Is there a caregiver on site? Go to that caregiver. And like you said, hey, what are you calling us for today? Right? Don't freak out because they got all these things. Maybe all that's fine. Right? Oh, I want to make sure that their G-tube is still in the right place. Like, oh, okay, that's all you're calling for? You just need to, The other thing is destinations, like transport destinations. Like what hospital is going to be best for you? And be mindful of that you might have to drive an extra 10 minutes, right, to take the patient to the appropriate facility, right?
And be very careful. We have a tendency to see somebody in that electric chair with the G-tube, with the vent, and think pediatric.
Yes.
The patient's 35.
Exactly. Yes.
Be careful.
Yes.
You don't want to show up at the pediatric hospital with a 25-year-old.
Yes.
Because you assume they were a kid.
Yes.
When not all kids that are trach dependent with a G-tube are pediatric.
That's right.
A lot of them are.
Yeah.
Be very careful with age because they are still categorized by age. Now, some of these kids, you have to be very careful because some of them actually have a special agreement with a children's hospital to maintain their treatment as a 25-year-old because of the special needs and because the specialists are there that know how to treat them. They're oftentimes transferred to the adult doctors, but some of them at what might be defined as an adult is still being cared for at the pediatric hospital. Absolutely important you communicate and understand and involve the caretaker in all these decisions on transport, decisions on treatment, right? Decisions on whatever. There's so many things that we got to be careful on in communicating to these patients and caregivers.
When I was in nursing school, I was doing a clinical at a pediatric facility, and we were up on a med-surg floor, and they had this patient in there, nonverbal. I believe he was autistic, and he was only like maybe 3 years old. He was a little guy. And nonverbal, didn't talk. He had this thing, he would grind his teeth. I mean, like you could hear that noise, and he would just sit there constantly. Like you could look at his teeth, and he'd ground it. This
makes me cringe.
Oh yeah, it was. I felt terrible. But he was an orphan.
Oh really?
And he would come into this facility all the time. I don't remember the story behind what happened with his parents or anything, but I remembered over my 12-hour clinical in there, kind of forming a little bit of a bond. Because you can kind of sense like when you're communicating with them or when they're responding positively to you or negatively, you can sense that, right? Even though this little guy couldn't say anything to me, I could sense that he was responding positively to me by the way his body. So not only do we have to be cognizant of how we're communicating, we have to be mindful of watching their body language, right? Yeah. And like, again, hopefully like we didn't have any caregivers. The nurses that were there were his caregivers, right? So we didn't have somebody to tell us this is his norm. We just had to kind of go off of instinct to figure out, oh, this is a positive thing. Oh, he doesn't like that, right? Yeah. And so, but again, most of the time pre-hospitally, I would say most of the time you're going to have somebody there, LVN, caregiver, parent a lot of the times, and they're going to be able to tell you ask them, Mom, are they nonverbal? Is your autistic son or daughter, are they nonverbal? Okay, what are their triggers? Because that's a huge thing with the autistic population is, again, we talked about it in the first part. Loud noises, lights, they don't like change. Some of them absolutely do not want to be touched, right? Maybe they have a favorite toy or a favorite thing that they like to hold or do. They're very tactile with their hands, right? Let them have those things to keep them calm, right? But again, back to the caregivers, communicating with them, finding out that important information to help keep your patient calm is going to make that call go a lot smoother.
The other thing that I think is important, I think we've kind of really nailed it as far as the history and how important it is to get a good story to involve the caretaker, because the history is so much more important in these patient interactions with all these barriers we're dealing with. Getting a full story is crucial, whereas with a normal, typical patient interaction, you can get by maybe with a truncated history.
Right.
Here, that's really not acceptable. You have to have a full history. Yeah. The other thing that I will say we haven't talked about much yet is physical exam. Yeah, those objective things. Yeah. We as providers, sometimes we'll do a real cursory physical exam because we know the chief complaint is XYZ, like an ankle maybe, or a trauma with a broken arm. Right. We will do a truncated physical exam or a focused physical exam. In these cases, we really can't, because most of the time the chief complaint is, something's wrong. I can't figure it out. Normally Johnny is acting a certain way. Right now he's acting really agitated, or he's really not acting right. He's really seems a bit altered here. This isn't his normal behavior. Yeah. And so your physical exam becomes so much more important now, just like the history. We're noticing the cyanosis at the fingertips, or looking in the mouth and you see these lesions, or
listening to breath sounds.
Listening to the heart, palpating the abdomen. Mm-hmm. Wow. You push on the belly, he's real firm and rigid, and you touch him, he's
away.
He's crying now, and he's you might be dealing with an appendicitis, right? Who knows? The thing is that, again, the caretaker is so important now. Mm-hmm. Asking the caretakers specifically, in the caretaker's defense, they may assume you just know this. Right? Because they're not going to be able to communicate everything to you in a few minutes, right? You're going to really have to ask them, how does Johnny tell you that he's in pain? Mm-hmm. Right? So as you're doing a physical exam, Johnny, you're looking for that cue.
Wince,
that you right, or that's exactly why I called, because I think he's in pain somewhere. Yeah. I don't know where, but something's wrong, right? And so understanding that, and the caretaker will be able to help you understand too, not just pain, but when Johnny's happy, he does this.
Right.
When he's hungry, he does that. The caregiver understands how they communicate, and you need to get that information quickly so you can understand some of what's going on with pain. Now, hopefully they're with you so they can kind of interpret for you, but I think that's a really big part of it is understanding the value of a physical exam with these patients that can't verbalize where they're hurting, like a normal or typical patient might be able to. There's that communication barrier.
And be gentle as you're doing these things, as you're palpating things. Like, be a little bit extra gentle, because it could, again, especially if that patient doesn't like to be touched, right? You got to go through there, and don't be Mr. Knuckle Dragon Fireman guy and just grabbing a hold of things. Like, be gentle, be calm, keep calm while you're doing these things. That'll help a huge amount.
And on that point, I think there's some tactics that I was taught that I think are really, I use them on my pediatric patients a lot, but there's some tactics I think that can be really helpful here. If you're just listening to our podcast, you're not going to be able to see what I'm about to do, so I'll pretend like you're visually impaired.
You about to choke me out, or?
No. Is that my stethoscope, right? Mm-hmm. If I'm going to listen to the heart and the lungs, I have my stethoscope out, and then I don't take my stethoscope off or put it back around my neck and then put my hands on the abdomen. They got used to me putting my stethoscope on their chest and over their heart and listening, and it's not painful. They're kind of trust me with this apparatus I have in my hand, and when I go to listen to the abdomen, I'll use that as a chance to palpate. Mm-hmm. I'll use my stethoscope to lightly palpate as I am listening. Mm-hmm. So it's really not much different than what was happening up top. Right. And I keep that stethoscope on to maybe have the caregiver help me to lean them forward in their chair a little bit so I can listen to the lungs, which I need to do. Mm-hmm. But as I'm doing that, I'm lifting up the back of the shirt, and I'm able to view, is there a bed sore back there, whatever, right? So being really strategic and combining physical exam regions together in a way where there's not a huge transition between things, because you have to respect the fact that maybe this autistic patient, when you do something different, they got to get used to that new thing again. Right. But if you do multiple physical exams with that stethoscope, where normally you wouldn't do that, by trying to group together physical exam things in multiple body regions with the same technique, it can help to facilitate the transition into the different areas. Whereas if you're doing your physical exam like you normally do with a typical patient,
not going to work.
Where it's almost truncated, it creates a new thing, a new thing. So trying to be sensitive to that can be a tactic I've used, and I use it with kids, but it can be good too with an adult that's got some autism or some other developmental delays.
Yeah, and if you start seeing them getting irritated, or the caregiver's telling you, hey, he doesn't like that. Like, okay, obviously you have to weigh out priority. Like, do I need to be doing this right now, or is this not so important? I don't need to be, like you said earlier, about a blood pressure. Because you put that blood pressure cuff on their arm. Okay, now they've got that. Now it starts squeezing really tight, and they're not understanding, why is it squeezing my arm so hard?
Yeah.
Right? And that could make them, and you're not going to get a good reading anyway.
Yep.
So what's the point? If they start moving their arms.
So key.
So, it's...
I think, one thing that, before we leave communication, I think we really should address the behavioral health issues in agitated patients, right? Oftentimes an agitated patient is agitated because of some behavioral issues. And I think we sometimes call it verbal de-escalation, right? But really what we're doing is what we learned in kindergarten.
Yeah.
is understanding that most of what we communicate is tone and body language.
Yeah.
This might be a good time to talk a little bit about the balms.
Oh,
right?
yeah.
Subconsciously, that's right. No, I mean, we kind of make fun of each other with our little quirks that we have in the studio and the way we communicate. Right. But the reality is that when somebody sees your hands when you're talking, that's subconsciously that's a way to build trust.
Yeah, you're non-threatening.
Yeah.
Because, you look at it from a defensive perspective. If I think about a police officer, that's why you never, police are always telling people, get your hands out of your pockets.
Yeah.
Because that's where the damage is going to come from, right? It's not going to come from your head, or, I guess they could kick you or whatever, but you can see their legs, right?
Yeah.
But it's what's in somebody's hand. Do they have a knife? Do they have a gun? Do they have some sort of weapon? If you've got your hands up like this, it's showing like, hey. And it's kind of that universal, it's almost like choking, right? It's that universal sign of, hey, this is what's going on. This is like a universal sign, like almost like I come in peace.
Yeah, you can trust me.
Yes, exactly.
Yeah.
And that's a nonverbal way of communicating that to people, that, hey, I'm not here to hurt you.
So that's one tactic, is to use your hands. Don't talk to them like this. Don't talk to them with your hands behind your back. These are subconscious things that are really shooting your trust down the drain, right?
Yeah.
Right in the foot. The other thing that's important to remember, too, is that we should all be aware of what our neutral face is. It sounds silly.
No,
and we haven't talked much about this. Or
thing.
have we talked? I think we've talked about this.
No, but it's been RBF is a thing.
What's that?
Resting faced.
Oh,
yeah.
That's so funny.
Yeah, a lot of people say, that girl's got RBF.
Oh, that's
it's
so
just
funny.
like they're not trying. There's a couple of nurses at the hospital that they're super nice people, greatest, but when they're just calm or they're focused, it looks like, oh man, she's mad. No.
That's
gotta
funny
be,
to hear.
You have to
it's
be.
nothing. They've done nothing wrong.
Yes.
These people with that kind of their. We work with an individual.
We should say RGF, resting grump face. Maybe it's a
Resting
better.
grump face,
maybe that's a better way.
So you really should be aware of what your resting face or your neutral face is, because look at yourself in the mirror and just relax your face.
Yeah.
Like, do you have because some of us, and it's just have that neutral face looks pretty negative.
Yes.
Or scary or angry or whatever it might be. You got to be aware of that, though.
Yeah.
And then intentionally try to turn that.
Put a smile on your face.
But you don't want to do it in a way that's artificial. They did a study on this, and they actually our eyes can see authenticity with smiles. That's a fake smile. That's a real smile.
Yes.
It's interesting. It's really true.
Oh, yeah.
We are subconsciously, again, most of what we communicate isn't what we say.
Yeah.
When I say communicate, we think words.
Yep.
But most of what we communicate is body language and tone, inflection.
Yep.
Yes.
Yesterday we were on a plane coming back. My wife and I were on a plane and we were taking off from LA. And my wife looks down. The guy was on the ground doing the flashlight thing, signaling the pile in the back. And I was reading a book or doing whatever. And my wife's like, he just looks happy. And I'm like, who? And she goes, the guy on the ground. And I'm like, what? And I looked out, and it was just this dude, and he wasn't smiling or doing it. He just had this face where he looked like a peaceful, happy guy. We're not saying I've never met this guy, but she just, exactly to your point, just by seeing this guy at an airplane window could tell, that guy just looks like a happy dude, you know? And it was all about how his face was.
So this is really important now when we're dealing with a patient that's going to get most of the communication by a typical patient might be maybe 50-50 with verbal tone and body language. But with these patients with special needs, there's a lot of subconscious communication going on. Right. Yeah. So I think it's really important, keep your hands up, keep, speak in a tone to the care provider and to the patient. That's calm.
Calm, slow.
Yeah, nice and
knowledgeable, sound like you're confident in what you're doing. Hey, it's okay. We got this under control.
The other thing that I think I would want to share before we leave this communication piece is that when we have those patients with behavioral barriers that we're trying to treat, is to remember with verbal de-escalation, the SAVE mnemonic that we talked about before. Being supportive to that patient that can understand what I'm saying, maybe like my friend I mentioned that's 47, and he's having a medical emergency, and now we've come into his home and he's in this ambulance now in a new environment, really scared. Is when we're communicating with our hands and calm voice, is now the words that we say, we got to be really intentional. And I like the SAVE mnemonic. Is when we're trying to communicate something, the S is support. Something, hey, Johnny, I'm your friend. I want to help you. Thank you for letting me come to your home. Being supportive. There's a lot of different ways to say it. This is, again, going back to what you learned in kindergarten. That's the S in SAVE. Do you remember the A, what the A was?
I don't remember.
Acknowledge.
Acknowledge, that's right.
Yeah. And so by acknowledging them, wow, Johnny, this must be scary. Have you ever been in an ambulance before?
Yep.
Whoa, let me show you some of these drawers here. And, really acknowledging the fact that this is a new environment for them. And that's really, and then to validate it, which is the V, to say this must be scary for you. To be out of your home, and to be the fact that this is the first time in an ambulance, and to recognize that and to validate it, and then to name the emotion.
That's right.
E, emotion naming, and to say, "Wow, this must be scary," or "Wow, this might
overwhelming,
be overwhelming," or whatever. And use small, simple words. It's not a time to impress people with vocabulary. Like this must be scary. Right. But that SAVE mnemonic, though. And this can be used in any verbal de-escalation situation. Obviously, with an angry, psychotic, guy on an overdose or something.
You must be really angry.
That's different.
You look like you want to cut my head off.
That's where physical restraints and chemical restraints come in, right? So
it's just like when you talked about the face, like you just got one of those faces. I just want, you know what I mean? No, it's super important to have the mindset of de-escalating, and I know a lot of times with just run-of-the-mill pediatric patients, one of the things most providers do, get the glove, right? Blow up the glove, make a little turkey on it. Like, for the most of the pediatric patients I've had, it's something like, oh, this guy's kind of funny, right? He's being funny, he's being goofy, must not be too serious, right? I'm not having to say that. They're realizing that based on the fact that, oh, he's taking time to blow up this toy and then give it to me, and he's making funny noises, or he draws a face on it, like, and then he gives it to me as a gift, like that's somebody I can trust. Like that simple little thing, now the kid's kind of distracted by this thing, and oh, this isn't quite so scary. It's not so overwhelming. This isn't so bad. A lot of those same techniques can work with our special needs patients as well.
And I think you'll kind of, like you and I, we've kind of got our own style.
Yeah, right.
You'll have your own style of communication, and these special needs patients, to overcome those treatment barriers, we've got to have that intentional plan using some of what we've talked about today to be able to communicate with the patient and the caregiver and understand and respect their position and where they are. I think that's huge. It's so important. So let me ask you a question. Do I have a positive or negative face? Like,
it's pretty negative. I'm just kidding. No,
really, what do you think?
No, you have a positive face.
I was going to say you do too. I think when I see you, you seem to have a I don't know. Maybe it's because I know you and I know you're so positive, but
yeah, my wife would probably differ with you. That guy's a jerk.
Yeah, no, what my wife would say.
That guy's an idiot. Yeah, I have that face that that guy's an idiot. That's and no, that's super important. And again, if I have had partners on an ambulance where whether somebody has special needs or not, the patient can read that body language like, oof, man, that guy looks angry or she looks really mean. So. Yeah. It's very important to be mindful.
Be aware of that. Yeah. Cool. Well, let's head into our last section. We're going to talk about some of the legal implications and some other things here as we close this out.
All right.
When we get into these situations, it's easy to get freaked out.
Oh, yeah.
Right?
Very much so.
Take it easy.
Slow down.
Yeah. Communicate with a caregiver. Remember some of these skills. Get the information that you need.
Yep.
Because when we rush and get freaked out about a patient situation that we're maybe a little uncomfortable with or maybe not as familiar or have lack of experience in, we tend to rush and skip things.
Yeah, get ourselves in some trouble.
Here's a quick story.
Okay.
And I shared this with you.
You've got your serious face on now. This is a serious story.
No, this is a serious story because this patient, the paramedics that were caring for this patient ended up, I don't think they lost their jobs, but the department was sued by the state. Anyway, I'm not going to say where the department was, but it was a prominent department, and there was a patient that they were going to care for that had some significant medical disabilities, physical disabilities based on a disease process, and this patient could not communicate in the typical ways, and because of the emergent situation, the care providers, which is totally understandable. I've been there. It's when you get a crazy situation, sometimes you just want to load and go.
Yeah.
Well, that's what they did. And like a bull in a china store, they loaded the patient up to get him to the hospital. But nobody thought to ask if the patient could communicate. And if they would have talked to the care provider, they would have known that on his electric card or whatever, he could communicate with the computer. And if he could have communicated, they would have known he did not want to be transported. And so they were sued, and they lost because they were guilty of kidnapping. They took somebody, transported them against their will.
Yeah.
And they didn't know what was going on. And if they would have asked, it was so benign and easy, they could have taken care of it right there, and they would have no need to transport. They were just missing a piece from the ventilator. All they needed was this. That's all they needed. Well, and I read the court documentation, and I could see it happening.
Oh yeah, very easily.
The tension's high, and it's like, just load them, get them on, let's go.
Give them a dose of diesel.
Yep.
I hate that saying.
But they were convicted of kidnapping. So again, communication was the last thing we talked about.
Yep.
But if the patient can communicate, you better be able to document that you did it.
Right.
Speaking of documentation, that's something else we got to talk about today too, right?
Yeah.
We'll get to that in a minute. But the communication and making sure legally you are respecting your patient with dignity.
Yes.
And you're also giving them their autonomy.
Yes.
We absolutely have to do it. Just like we teach our ACDC thing, right? If to determine if someone can make an autonomous decision, right, the A, we have to absolutely build a case for consent.
Right.
Legal.
Yep.
And mental, capacity, right? To get that consent so they can make an autonomous decision, A and C. And then AC, DC, we got to be able to disclose the information to the patient so they can then communicate it back. We have to determine whether or not, a patient's able to make the decision for themselves. That's what the ACDC acronym helps us to do. And if a patient cannot consent, if they don't have that capacity to be able to do so, then we make the decision for them.
Right.
But we have to remember, though, that oftentimes these patients with these special needs, their brain is fine.
Oh, yeah.
And if they can make an autonomous decision, we have to respect their autonomy. And we can't just assume certain things like that group did. And I don't blame them. I mean, I can see how that can happen easily. Yeah. And that was a rare situation.
Kind of a shame that went that far.
Yeah.
Because I'm sure that they weren't doing it out of, being rude or mean to this patient.
No.
They probably thought they were trying to do what was best for the patient.
Save their life.
Yeah, exactly.
Yeah, right. Remembering though that these patients oftentimes, even though it may be difficult to communicate, if they can communicate. Another story, real quick.
Mm-hmm.
One of my dear friends had a drowning accident, near drowning, or I guess what we call that now, submersion injury, in a hot tub. And now I think he's a manager of a bank now. But growing up, it was so difficult to understand him. He had difficulty walking because of the brain injury. I had difficulty communicating verbally. You have to really get to know him to understand him.
Yeah.
Well, now he's some financial guru at a bank or something, but he uses a walker and all that. But his brain is fully intact and able to make decisions.
Yep.
But boy, if you thought for 1 minute when you got to their house, and you thought that maybe this individual wasn't able to communicate, so we're just going to grab him and put him on and go. I don't care.
That's going to be illegal. Well, I think of like Stephen Hawking's.
Right.
You know, I mean, brilliant guy, you know, at least from a scientific, brilliant guy, had all his mental faculties about him. He just had problems but he would communicate through the iPad like you were saying in this situation. So very important to slow down when you get on these scenes. Slow down, take your time, do a good assessment, use the caregivers or whoever's on site to help you so that you don't get yourself in a legal bind with these patients. And also the documentation. Right? You know, like, how did you communicate with this patient? Document how you did that. If they were nonverbal, document that they were nonverbal. Did they have capacity? Yes. How did you determine that they had capacity? Right? Because maybe they can't repeat it back to you.
Or the caregiver says, no, they're not acting right. Normally this patient would be able to communicate with you and I to tell you how they're feeling right now. This is not normal. They are altered. You know right then, the whole ACDC acronym doesn't matter. You are now making decisions for them with a caregiver. You're making decisions for them.
Or maybe the caregiver has medical power of attorney.
True.
You know, or it could be the parent. So they can, you know, force them to, not force them, but they can say, yeah, he needs to go. They can have the legal authority to make that decision.
That's a good point.
Super important.
Legal power of attorney is a huge thing, and that doesn't just mean special needs. Could be
geriatric patients is a huge one. Obviously, PD patients.
You know what's common in all of these situations is really what we're talking about, and I think this is probably the most important thing that we could say here is that in any patient we see, regardless of intellect, behavior, physical abilities or disabilities, age, location, socioeconomic class, whatever, gender, orientation of any kind, creed. Anyway, you get my point. What we're talking about here is dignity and respect. That's it. We should do this with all patients. And I think what's so special, no pun intended, with the special needs population is that it really creates an environment where this is so important because sometimes it may not be fully obvious on how we communicate or how do we really give a sense of dignity here and respect to this patient population or this individual's, situation. And that, I think, is something we should be doing with every patient.
Yeah, for sure.
But this is a unique challenge, though, with the special needs patient, right? Really loving them when they can't care for themselves, which reminds me of one of the most important things we could talk about is the fact that this is one of the most vulnerable patient populations.
Abuse is a big problem, especially in facilities where they have multiple special needs patients. A lot of these patients, I've numerous TBI patients in their 30s, 40s, 50s are in nursing homes for the elderly, right? And you go in, you got this 35-year-old that suffered a TBI from a car wreck, and now they're, in a nursing home. And they can easily be victims of abuse. That's
really sad.
It's
that you would do this. There aren't a lot of things that just kind of make me angry. But it really sickens me that this really happens. So, in our pediatric lecture when we talked about child abuse, remember the acronym we taught our students, 10 4 faces P? Some of the components of that are important here too. They're not children, of course, but, like certain things don't apply. Like, on a side note, if you have any bruising in a 4-month-old or less, not normal. Okay, but we're not talking about 4-month-olds here, but there are some bruising patterns though that I think we can share here that are important. If you have that patient, that nonverbal patient, and you're moving them and you see lots of bruises in different stages of healing, Remember, bruises at about 24 hours are red,
Yep.
and then they get blue-purple after about 24 or 48 hours, and then they turn to a yellow-green,
yeah.
and then they go yellow-brown after 10 to 14 days. If you see lots of different colors, a rainbow of colors of different bruising patterns,
It's a red flag.
Red flag. If you see bruising patterns of hands, or maybe
Teeth,
or
cigarettes, which isn't as common.
yeah, or even instruments, or cords or whatever, there could be some pretty nasty stuff happening, and you may be the one to see it and to report it. So. Anyway, I think it's worth mentioning only because this patient population is so vulnerable.
Yeah.
I think it's really behooves us to make sure we mention that.
And one of the biggest forms of abuse, I think, and I've seen, has been negligence. It's not actually them putting their hands on the patient, but you get a patient that's got these horrible ulcers that
neglect.
Obviously have not been treated or cared for in a long time, and they're infectious, and it's like, oh my gosh, this patient is not being turned or moved properly.
That's right.
They're not, padding, doing all the things that they're taught to do. They're not doing any of those things with these patients, or maybe they're super skinny, like they're not being nourished properly. Right. So I think a lot of times the abuse is more from a neglect standpoint, or the other one is they're sitting and laying in their feces or urine for days. And I've had one patient, and this was not in a facility, this was in a home, a hoarder house, but it was so bad that the sheets of the bed were attached to her. And I mean attached to her. They had to be removed surgically in the ER. We had to take the bed sheet with us because the feces had bound the sheet together to her skin. She'd been laying in it for so long. It was, it was just horrendous, So I think that's probably the biggest, at least in my experience. I'm not saying globally, but in my experience,
Neglect.
the biggest form of abuse I've seen has been neglect, especially when you go into these facilities where they're dealing with, maybe over 100 patients, and they all have, and that can be, that's tough, man. That takes a special person to work in those places because that's not an easy thing to deal with day in and day out.
I'm really glad you brought that up. It's not just the non-accidental trauma, which is the physical abuse. It's the neglect, which is just as dangerous.
Can be just as detrimental patient-wise.
And the third type we talked about in that lecture is plays in here too, is the emotional abuse.
Yes.
Not all caregivers are created the same.
No.
There may be caregivers that are state appointed they should not be that caregiver.
Yep.
that is emotionally abusive. So really being mindful of that caregiver not letting the patient speak or communicate in certain situations could be bad. But if there are red flags, you see that it's not right. Talking to adult protective services or child protective services is key, because in some states you're a mandatory reporter, right?
Yep.
So you gotta be careful.
In this new role that I have, I've contacted APS only a few times in my career when I was out in the field, and now in this new role, I've had numerous times where crews have called me like, hey, I don't know if we should call APS, or, they think it's almost like this taboo thing. And so I was kind of wondering, and I actually called APS, and I was like, tell me, give me some more history about, if we call you, is there a line, that...
Yeah, what'd you learn?
And so basically it was you can call us for anything. If you even think that there's something going on, even if it's not a negligent thing or a criminal thing or anything like that, but just an adult that needs help, call us and we'll go out and do an assessment. We'll go out, we'll put our eyes on it from their standpoint and look at it and see okay, do they need some help with cleaning? Do they need some help with finances or whatever, food services or whatever? It doesn't always have to be from a neglect standpoint, but if you even think that that's what we're here for, that's our job, right? Is to go out and do an assessment and say do we see signs of abuse? That's what they're trained much more than we are as first responders. They're much more trained in looking for specific signs of abuse. And so if you're a first responder and you're afraid to call APS, don't be. That's what they're there for. They want to do their job. You're not going to get anybody in trouble necessarily if they go out and they're like, no, we appreciate you bringing this to our attention. You saw something that you thought was off and you wanted to do what was best to protect your patient. We'll go out there, do an assessment, and take it from there.
And remember, we miss this a lot.
Oh, a lot.
So,
I think a lot of it's from fear. Oh gosh, is something bad going to happen? And I don't want to be the person throwing somebody under the bus when maybe it was a well-meaning caretaker or parent, right? APS can be a great resource for them.
And these patients are so vulnerable and so exposed. We need to be an advocate for them if they are in a bad situation.
Yes.
That's huge.
Always think of when you go into these nursing homes. I know dealing with nursing home patients and nursing homes in general, it's not the patients, but dealing with nursing home calls, right? It's an unfortunate reality that nursing homes sometimes abuse 911. They call 911 a lot when they shouldn't be calling 911. They should be calling a non-emergency transfer service or something like that. So I get it. Like in the last one of the last districts I worked in, we had 8 nursing homes just in my district.
Yep.
So I've made a lot of nursing home calls, but it's not the patient's fault. No. Right? And just always think of, if this was my grandma or grandpa or mom or dad or whoever, my loved one, that this was my patient, like how would you want them to be treated? Right? And so just always kind of, and you're only going to be with them for a short amount of time. So, you know, it's not like you got to deal with this for hours and days and months or whatever. Like, be kind, show them dignity, show them autonomy, and if you see any red flags that there could potentially be some abuse patterns, don't be afraid to report it.
That's huge.
Yeah.
So we talked a little bit about the different populations. We talked about communication, and then we talked about some of the legal considerations here. But ultimately, I think, just to bring it home, respect your patients, give them the autonomy that they have the right to have, right? Yeah. And then also remember, this is a vulnerable patient population that really may need some advocacy, may need to report abuse. I mean, if you're going to see a patient population where abuse is happening, this may be the one.
That's right.
It's a very vulnerable patient population.
Yep. Well, it's a good topic. Very important.
It is.
See you on the next one.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.